So I've been charged with talking about critical care and giving you some quote-unquote pearls. And so this is probably a typical patient that we all have probably seen in the intensive care unit. The patient has intubated. We see the sutures from an abdominal surgery. We see the Broviac catheter placed. So probably a patient who has short bowel syndrome or had some significant intestinal surgery that's done recently. So what do we know about malnutrition in the pediatric intensive care unit? Well, and some studies have shown 24% of patients in the Netherlands meet criteria for malnutrition, and up to 53% of Brazilian children have meet definition for malnutrition. So what does that do? Well, these patients may have higher rates of infections and non-infectious complications, increased mortality. They tend to have longer hospital stays, and they have, of course, increased cost. So I definitely will not totally review protein, energy, nutrition as Praveen done this earlier, but as he stated before, it's multifactorial. You have increased demands secondary to the metabolic stress response, failure to estimate energy expenditure accurately, and inadequate substrate delivery at the bedside. So this is, the next two slides are actually borrowed from the pediatric slide set that Dr. Schulman mentioned, which is actually very good reference. So you have a patient that's in the ICU for whatever critical insult, trauma, surgery, and they have a central response mediated by their hypothalamus, their pituitary, leading to ACTH stimulation. And you also have a local response, the tissue directly that's affected by this insult. Systemic mediators such as cytokines, reactive oxygen species lead to in-organ responses. And so what happens is the patient may have elevated white count, you may see an increase in acute phase reactions, renal failure, ARDS, or frankly, the patient may just have multi-organ failure. And the definition of this is systemic inflammatory response syndrome, which is simply a constellation of all these syndromes, all these signs and symptoms that you see in critically ill children. So in this first phase, this pre-resuscitative phase, is a hypometabolic phase, usually within the first day or so, and you may see some tissue injury at this time period, gut ischemia, for example. Over the next few days, you may have more of a hypermetabolic flow, but the resting energy expenditure may often be reduced. These patients may be ventilated, sedated, and children typically are not growing well during this time phase, and you may see tissue reperfusion injury. So the recovery that can actually happen over weeks, this hypermetabolism can persist for months. And this is a patient who's at risk for chronic malnutrition, who's in the ICU, who's there for a prolonged period of time. You're more likely to see the children actually grow during this phase, but you also may see some second hit. This may be when the patient gets their first line infection, or the patient may have to go back for some other type of surgery, which may actually delay this recovery phase and actually start it all over again. So, nutritional assessment. So typically people use Z-scores from the World Health Organization, weight for age, length or height for age for children less than 2, or you can use the body mass index for kids older than 2. So patients are defined as being malnourished when their Z-scores are less than or equal to -2, and their BMI, or rather they're overweight when their BMI Z-scores are greater than 2 standard deviations. So what does Aspen recommend? Well, Aspen recommends that patients should have weights. Everybody's rotated through the ICU, and as you know, and even on the floor, you don't necessarily get the daily weights that you may want, especially in a critically ill child. There's always concern that you could worsen their medical condition, and sometimes it is more so just not a recognition of how important obtaining that weight actually is. Praveen mentioned earlier about some anthropometrics, mid-upper arm circumference, tricep skin folds, length, and BMI. But in the ICU, it may not be quite as reliable, and you may have some inter-user variability. And this is where training comes in as far as the person being able to reproduce their results. Laboratory data can be used, albumin, prealbumin, transferrin, and retinol binding proteins, but they tend to be less accurate in patients that are acutely ill. Prealbumin levels, which we talked about earlier being a measure of intake, but in patients who have liver disease, they tend to be lower. You can see C-reactive protein and prealbumin being inversely related. And this one study that looked at a cohort of children who had cardiac surgery, they saw a decrease in C-reactive protein was associated with a return to anabolism and subsequent increase in serum prealbumin. Interleukin-6, which may be a hallmark of the systemic inflammatory response that I discussed earlier, may actually suggest that patients are more at risk for nutritional deterioration. So this is some equations that you can use to determine the basal metabolic rate. The only issue with this is these are normal, healthy children. These are not the children that you're seeing in the intensive care unit. And so what typically people do is they add stress or activity factors, but unfortunately it may lead to inadequate measurements with potential overfeeding. So who's at risk for overfeeding? Well, these patients have very low activity. They may be intubated, they may be paralyzed, they may have less insensible fluid losses, and they're not growing, as we talked about before, during their acute illness. So overfeeding can lead to increased ventilatory effort because of an increased CO2 production, so you may have prolonged respiratory support. We talked about earlier it causing steatosis and cholestasis, and it also can place the patient at risk for infection secondary to hyperglycemia. Anybody ever seen this equipment before? Anybody ever used this equipment before? So this is actually a metabolic cart that, in theory, is going to do these measurements for indirect calorimetry. So it looks at the volume of oxygen consumed and the volume of carbon dioxide produced. And in underfeeding, it really promotes the use of endogenous fat stores with a sensitivity, rather this quotient, with a very low sensitivity, 63%. And it's supposed to be high specificity, sorry about that, and negative predictive value of 89%. When you look at overfeeding, you have an increase in this RQ quotient greater than 1, with a low sensitivity but higher specificity in those patients. So who should you use this type of testing for? So Aspen actually came out with some guidelines and some recommendations in 2009 about patients who should, in theory, undergo this type of testing. So they recommended patients who were underweight, risk of being overweight, or who were overweight, patients who had greater than 10% weight gain or loss during their hospital stay, if you were unable to wean or you were having an escalation of respiratory support, prolonged PICU stays, suspicion of persistent inflammatory state, such as bone marrow transplant, oncology, continued sepsis, and conditions also associated with other altered metabolic rates, or if you have any clinical suspicion for underfeeding or overfeeding. Boston Children's actually looked at a prospective cohort of patients that entered their intensive care unit, and using those criteria, some of those patients were screened using the indirect calorimetry. 62% of the physicians predicted or failed to predict the true metabolic state of their patients, and 83% of those children were actually overfed with an excess of 8,000 calories per week. And those kids less than 1 year. So we talked about before some of the complications you can see with overfeeding, and it seems to be especially true in those younger children who are in the intensive care unit. So this was, we talk about enteral nutrition, and so the goal is to start feeding patients as soon as possible. So this was a randomized controlled trial of about almost 700 patients, and it compared patients who were fed at 48 hours after admission to the ICU as compared to 3 to 6 hours. And those patients who were fed earlier had a decreased length of hospital stay from 16 to 13 days and actually had decreased mortality, 12% versus 8.5% in pediatric burn patients. So early institution of enteral nutrition has been shown to improve outcomes, but as we know, what happens in the intensive care unit? Those patients need to go for surgeries. They need to go for some sort of imaging study. Their feedings are stopped continuously or pretty frequently. They may not tolerate their feedings. They may have an ileus. They may be early surgical resection, so you're not able to even feed these patients. And the clinical guidelines that were published by the Canadian group actually also support evidence that early enteral nutrition will decrease the length of stay and improve survival. However, what's still a debate is how do you do it? Is it gastric or is it jejunal feeds? And there's still no significant evidence supporting one over the other. So Dr. Schulman talked about TPN beforehand. So the thought is that if you require 5 days to reaching goal feedings, those patients should be able or should be started on TPN. And there was suggestion that even the younger infants should be started sooner than that. So you're going to replace their fluid requirements, and you have to pay attention to their fluid losses. He mentioned urine electrolytes, or you can measure the drained fluid. There's significant sodium, chloride, and bicarbonate in these different fluids that really need to be replaced. You can have low phosphate levels, magnesium levels, and changes in your bicarb levels. This was a table that I use all the time looking at GI electrolyte losses that Sam actually published a couple of years ago. If you look at the gastric sodium content, it's 140 milliequivalents per liter. What does that compare to normal saline? What's normal saline? 154. So if you have significant gastric outlet drainage, you're almost losing normal saline in your TPN. And you look how some people usually start, or the recommendations for TPN is like 2 to 4 milliequivalents per kilo. So that's fine if you're not having a liter or liter and a half of gastric output. But if you're having that, you need to replace it. You also have potassium losses, chloride losses, and as mentioned earlier, you talk about ileostomy losses. Again, that's like half the normal saline that those children are pouring out and may or may not actually being repleted. You may need to add acetate to replete your bicarb. So knowing the exact electrolyte losses is very helpful, and sometimes you can just use urine electrolytes to be able to titrate your sodium if you need to add, or you can actually measure the fluid. Micronutrients, zinc, copper, multiple vitamins, selenium, vitamin D, and unfortunately, I think with the TPN shortage currently, there are more and more patients. For instance, I know one of my patients is selenium deficient, so that can be part of a problem with patients who are critically ill. We have a shortage of some of these vitamins that they may actually need. So these antioxidants, such as high-dose selenium, may lead to improved outcomes, but you need to have it to be able to replete it. So what about refeeding syndrome? And I know Praveen talked about it earlier. So these are some of the signs and symptoms that can occur after providing adequate nutrition to previously starved patients. You may see this with the anorexic patients, the patients with chronic liver disease, heart disease, and those patients who have malabsorptive states, like the short bowel patients, the cystic fibrosis patients, or patients who may have pancreatic insufficiency for whatever reason. So unintentional weight loss, greater than 10% within 1 to 3 months. If they're less than 70 to 80% of their ideal body weight. Prolonged NPO status, 7 to 10 days. If they have evidence of muscle wasting or chronic dysphagia or inadequate nutrition. So what's the pathophysiology? Well, there's a dramatic shift in the macronutrient metabolism. You're providing these patients with increased carbohydrates, so you're having an increase in insulin secretion. Glucagon's release is inhibited. And so you have activation of previously slowed anabolic pathways, and you shift from lipolysis to lipogenesis. And you end up with depletion of ATP. And so you may have reduced electrolytes and vitamins and migration of the electrolytes actually into the intracellular locations. So you may have low phosphate. So increased insulin leads to intracellular migration of phosphorus, and you need it for phospholipids, ATP, and for nucleic acids. Hypokalemia, the carbohydrate reintroduction, again, leads to increased insulin, which will shift potassium intracellularly, which we use when patients have hyperkalemia. Hypomagnesemia, which can be a cofactor for a number of different processes. Hyperglycemic, sodium retention and fluid imbalance with potential heart failure or pulmonary edema in those extreme cases. But again, as we talked about, as long as you're watching for this carefully and adjusting their feedings in a step-by-step basis, you hope that you don't see this problem. So in conclusion, malnutrition and overfeeding may lead to significant effects on critically ill children. The use of the basal metabolic rate equations may actually lead to an overestimation of caloric needs, which, as we mentioned before, has its own set of downfalls. And enteral nutrition has been shown to improve outcomes. Refeeding syndrome can lead to electrolyte abnormalities and must be monitored in high-risk children.